Welcome to the deep dive. Our mission, as always, is to take complex info. Could be surgery, could be metabolism, or like today, how the skin signals distress, and really break it down for you.
Yeah, make it clear, make it stick.
Exactly. Because well, it's our biggest organ, right? It's not just a barrier. It's constantly talking to us, signaling internal issues.
Like autoimmune attacks, mechanical stress, sun damage, even, chemical imbalances deep inside.
And that's exactly what we're tackling today.
Yep.
We're diving into 5 pretty different skin conditions: vitiligo, pressure ulcers, senile purpura, sunburn, and porphyria cutanea tarda, or PCT. They look totally unrelated on the surface.
Totally. But they all reveal something critical about what's happening systemically underneath.
Mhm.
So our goal isn't just definitions. We want you, the listener, to be able to spot the differences, get the why behind them.
And crucially, identify those associated risks, like links to other diseases.
Right. Moving beyond just the flashcard facts. Okay. We've got some solid, concise clinical sources here covering pathology, features, management for all 5. So let's just jump right in. Segment 1, autoimmune and genetic signals. This is where the body's own systems kind of go haywire.
Let's kick things off with vitiligo. You see those really distinct white patches, sharply defined. That's classic autoimmune, isn't it? What exactly is the immune system doing?
It is. In vitiligo, you've got these specific immune cells, the cytotoxic lymphocytes, T cells, basically, that start attacking the melanocytes.
The pigment-producing cells.
Exactly, the ones in the bottom layer of the epidermis. The T cells basically see them as foreign and, well, destroy them. It happens in patches, which is why you get those really well-demarcated areas with absolutely no pigment left.
And it can show up anywhere, or specific patterns.
There are patterns. Sometimes it's a curl, like on hands and feet, sometimes periorficial around mouth, eyes, or it can be generalized, quite widespread.
Okay, so the skin's white, but lots of things can make skin lighter. How do we nail down that this is really vitiligo? That seems like a common pitfall.
It's the critical distinction, really. Vitiligo causes true depigmentation. Zero color. Melanocytes are gone. The skin is just white, sometimes looks chalky under a wood's lamp.
Okay, deep pigmentation.
Right, not hypopigmentation where there's just less melanin, but still some color. A classic condition people confuse it with is tinea versicolor.
Ah, the fungal one.
Yeah, that infection messes with pigment production, so you get lighter patches, often a bit scaly, usually on the trunk. But they're hypopigmented, light, not stark white like vitiligo. Is the pigment reduced or totally absent? That's question number 1.
Got it. And typically, the patient doesn't feel anything. No itching, no pain.
Usually no. It's asymptomatic in that sense. And this is the big point the sources hit hard. Vitiligo is almost never just a cosmetic thing. It's like a flashing light for systemic autoimmune risk.
Right. Because if the immune system is attacking melanocytes,
It might be attacking other things too. That tendency towards autoimmunity rarely just stops at the skin. And the absolute strongest connection, the one you have to think about first with vitiligo, is autoimmune thyroid disease.
Hashimoto's, Graves, go.
Either one, yeah. The association is significant.
So someone walks in, new diagnosis of vitiligo. What's the immediate next step, the must-do test?
Check their thyroid-stimulating hormone. PSH. That's the primary screening test everyone agrees on.
Even if they have zero thyroid symptoms.
Even then, the chance of finding subclinical or overt thyroid disease is high enough that TSH screening is considered standard of care. It likely relates to shared genetic factors, specific HLA types that predispose people to multiple autoimmune issues. Thyroid and skin often go together.
Okay, TSH first. But what about other autoimmune conditions, like type 1 diabetes or Addison's disease? Should we be screening for everything?
That's a really good question. Gets into efficient practice. Associations do exist with those others. Type 1 diabetes, pernicious anemia, autoimmune adrenal or parathyroid issues, but they're much less common than the thyroid link.
So don't go ordering a huge panel right away.
Exactly. The guidance is clear.
Right.
Only test for those other conditions, like checking an HbA1c for diabetes or PTH or adrenal antibodies if the patient actually has symptoms suggesting them. Unexplained fatigue, weight loss, excessive thirst, dizziness, things like that.
Okay. But just for the vitiligo diagnosis itself, TSH is the key initial screen.
Right. Targeted approach.
Yeah.
And if we confirm vitiligo, what's the management plan look like?
Well, it's usually chronic, often progressive, meaning it spreads over time. though maybe 10–20% of people might get some spontaneous repigmentation.
Huh, interesting.
Yeah. Management depends on how much skin is involved. For limited spots, we often start with potent topical corticosteroids or maybe calcineurin inhibitors. Got to watch for side effects like skin thinning with long-term strong steroids, though, naturally. And for more widespread cases, then phototherapy is really the mainstay. Narrowband UVB is standard. It can help stimulate any remaining melanocytes and calm down the T cells. For really tough, fast-spreading cases, sometimes oral steroids or other systemic drugs are considered, but that's less common. The goal is always twofold. Stop the attack, encourage repigmentation. Okay, that covers the immune attack well. Let's switch gears now from T cells attacking to, well, a basic chemical factory breakdown. Porphyria cutanea tarda, PCT.
Yeah, a totally different mechanism. If vitiligo is the immune system making a mistake, PCT is more like a failure in a production line.
Specifically, the heme production line.
Exactly. PCP is actually the most common type of porphyria. These are all disorders affecting how we make heme, which is crucial for hemoglobin. In PCT, the specific problem is a deficiency in an enzyme called uroporphyrinogen decarboxylase, or UROD.
UROD. So if that enzyme isn't working right, these intermediate chemicals, porphyrins, they just build up.
Precisely. They build up in the liver, spill into the blood, and importantly, accumulate in the skin.
And why is that bad for the skin? What do these porphyrins do?
They are incredibly potent photosensitizers. This means when they're exposed to UV light, especially the longer UVA wavelengths, they absorb that energy and get, well, excited.
Excited.
Chemically excited.
Yeah.
And they react very aggressively with oxygen in the skin tissues. This generates a huge storm of reactive oxygen species, ROS. Think of them as tiny toxic bombs going off in the skin.
Ah, so it's not the UV light directly burning the skin like a sunburn. It's the porphyrins reacting to the light and causing internal damage.
Exactly. The UV light is just the trigger for the porphyrins already there.
And what does that ROS damage look like clinically?
It's a pretty specific picture, usually on sun-exposed areas like the backs of the hands, forearms, face. You see extreme photosensitivity leading to recurrent, tense blisters, vesicles, and bullae.
Painful, I imagine.
Oh, yeah. And when these blisters heal, they often leave scars, and the skin becomes incredibly fragile, easily torn or damaged. You also see other distinct features like patches of hyperpigmentation and hypopigmentation, a sort of mottled look, and quite uniquely, facial hypertrichosis.
Excessive hair growth on the face. Yeah, often fine hair on the cheeks, temples, forehead. It's quite characteristic when you see the whole picture. Blistering, fragility, pigment changes, and that hair growth, all in sun-exposed areas. Okay, vivid picture. Now, the sources really stress something interesting. So many people might have this UROD enzyme deficiency genetically, but they don't actually develop PCT unless something triggers it.
That's absolutely key to understanding PCT. The triggers are things that put extra stress on the liver and that whole heme synthesis pathway. They essentially push a susceptible person over the edge into active disease.
And what are these triggers?
The main ones are chronic heavy alcohol use, exposure to estrogens like in birth control pills or hormone replacement. Smoking is another one. And critically, especially relevant for systemic health, hepatitis C virus infection, HCV.
Hepatitis C. Wow. How does a liver virus trigger a skin condition like this?
Well, the liver is ground zero for this enzyme problem. UROD does most of its work in the liver. Chronic hepatitis C causes ongoing inflammation and damage in the liver. This further suppresses the already low UROD activity, tipping the balance dramatically towards porphyrin overload.
So a patient with new PCT, you absolutely have to screen for Hep C.
Absolutely. It's a major treatable trigger.
This sounds like a management nightmare. You've got
Yeah.
genetics, enzymes, triggers like alcohol or Hep C. How do you approach treatment?
It's definitely layered, but highly targeted. First, you want to get rid of the triggers if possible, stop alcohol, maybe change estrogen therapy, treat the Hep C. Then you need to reduce the porphyrin load itself.
How do you do that?
Two main ways. One is phlebotomy.
Therapeutic bloodletting. Really?
Yeah, scheduled blood removal. The goal is to reduce the body's iron stores.
Why iron? What does iron have to do with porphyrins?
Iron acts like a catalyst in the liver. It speeds up oxidative reactions that both generate porphyrins and inhibit the UROD enzyme. So too much iron makes the enzyme deficiency functionally worse. By removing blood, you lower iron stores, which takes some stress off that pathway and lets the UROD work a bit better.
Fascinating. Okay, phlebotomy for iron reduction. What else?
The other main treatment is low-dose hydroxychloroquine.
Like the anti-malarial.
The same drug. At low doses, it seems to bind to the excess porphyrins in the liver and help mobilize them for excretion in the urine. But the dose has to be low and carefully managed. Too high a dose can actually cause a massive sudden release of corphins, leading to a temporary severe flare-up.
Tricky. Very. And maybe the most important part, if a patient does have hepatitis C, treating and curing the hep C with modern direct-acting antivirals is often the single most effective way to resolve the PCT long-term. Incredible. A skin disease treated potentially by curing a virus and phlebotomy. Shows how connected everything is. How do we confirm the diagnosis definitively?
Biochemically, you need to measure porphyrin levels in the plasma, or, more commonly, the urine. You'll find markedly elevated levels, particularly of uroporphyrin and heptacarboxyporphyrin.
And other labs might show?
You often see mildly elevated liver function tests, the LFTs, reflecting that liver stress, and sometimes evidence of iron overload on iron studies, consistent with the role iron plays.
Wow. Okay, that's a real journey into biochemistry. Let's completely shift gears again,
Yes.
away from T cells and enzymes and into pure mechanics, the physical stress of just not moving. Pressure ulcers, bed sores, decubitus ulcers, that whatever you call them, the cause seems brutally simple, right? Just pressure. But the results can be absolutely devastating. Brutally simple is a good way to put it. The
Yeah.
definition itself is all about mechanics. Localized damage, necrosis of the skin and the tissue underneath, caused by prolonged, unrelieved pressure, usually over a bony bit, like the sacrum, heels.
Sacrum, heels, ischial tuberosities, those sit bones, elbows, even the back of the head sometimes. Anywhere bone is close to the surface and the person isn't shifting their weight.
Walk us through what's happening at the tissue level. How does that pressure actually kill the tissue? It's ischemia, right?
Exactly. It all boils down to blood flow in the tiny capillaries. Our capillaries need a certain pressure inside them to stay open, maybe around 15 to 30 millimolar Hgs. If the external pressure on the skin from, say, a mattress or a wheelchair seat is higher than that capillary closing pressure,
It just squashes them flat.
squashes them flat. Blood flow stops completely in that specific area. That's ischemia. No oxygen, no nutrients getting to the cells. And if that pressure isn't relieved pretty quickly, we're talking potentially just a couple of hours.
Hours, that fast.
It can be. If the pressure isn't relieved, the cells start to die from lack of oxygen. That leads to irreversible damage, necrosis, and eventually the skin breaks down, forming an ulcer.
So knowing who's at risk seems even more important than treating the ulcer once it's formed. Who are the high-risk individuals we need to be watching? Risk factors really cluster around two main things: not being able to move and not being able to feel or react to the pressure. So immobility is huge. Think post-stroke patients, spinal cord injuries, people heavily sedated after surgery, frail elderly who can't reposition themselves easily,
Okay.
and the sensation part.
Neurologic impairment is key. Patients with advanced dementia might not perceive the discomfort. People with severe neuropathy, like in advanced diabetes, literally can't feel the pressure building up. Reduced consciousness for any reason is a major risk factor.
Any other factors that make it worse?
Yeah, absolutely. Malnutrition is a big one. Right. The body doesn't have the protein and nutrients needed to maintain skin integrity or repair damage. And poor overall perfusion, like in patients with really low blood pressure or significant peripheral vascular disease, means the tissue is already borderline hypoxic, so it tolerates pressure even less well.
Okay, so we know who's at risk. Now, the diagnostic challenge. An ulcer is a wound, sure, but pressure ulcers need to be distinguished from other common types, like arterial, venous, or diabetic ulcers. How do we tell them apart quickly?
This is core clinical skill. Location, appearance, and the patient's context are everything.
So recap pressure ulcers first.
Key is location over a bony prominence. Context is immobility and sustained pressure. Appearance can vary from intact red skin, stage 1, to deep craters involving muscle or bone, stage 4, often with irregular margins.
Okay, now arterial ulcers. Arterial insufficiency ulcers, think lack of blood in, caused by poor arterial flow. So locations usually distal toes, tips of feet, maybe shin. They're typically very painful. Appearance is classic. Punched out, meaning deep, sharp edges, often with a pale or necrotic base. Surrounding skin, cool, pale, maybe hairless, got it. Venous ulcers. Venous insufficiency ulcers, think blood can't get out. Caused by venous stasis, pooling blood. Location is classic. Above the medial malleolus, the inner ankle bone, or sometimes the shin area. Appearance is usually shallow, irregular borders, often with a lot of weeping exudate, and the surrounding skin tells the story. Swelling, edema, brownish discoloration, hemoceder and staining, and often stasis, dermatitis, red, itchy, scaly skin, usually less painful than arterial ulcers. And finally, the diabetic foot ulcer, diabetic neuropathic ulcers, but primarily due to nerve damage, neuropathy, plus pressure. Location is key. Plantar surface, the sole of the foot, especially under pressure points like the ball of the foot, metatarsal heads, or the heel. Often painless because the patient can't feel it. They can look deep, like a crater, and are often associated with foot deformities like Charcot foot. That's a great breakdown. Location, appearance, context. Also, important point about bacteria, right? Pressure ulcers often get infected, but the bacteria don't cause them initially.
Absolutely critical distinction. The pressure causes the tissue death, the necrosis. Once that happens and the skin barrier is broken, bacteria from the skin or environment will inevitably colonize the wound. True infection is a common complication, but the bacteria are opportunists. They didn't start the fire.
Okay, so given that the root cause is mechanical pressure, prevention has got to be the main strategy, right?
Function.
Because the sources are unanimous. The single most effective intervention for preventing pressure ulcers in high-risk immobile patients is pressure redistribution, taking the pressure off.
Exactly. If you eliminate the pressure, you eliminate the ischemia.
How do we actually achieve that in a hospital or care home? It sounds simple, but
It involves using specialized support surfaces, moving beyond standard foam mattresses to things like low air loss mattresses, air fluidized beds, or alternating pressure mattress systems that automatically inflate and deflate different cells to constantly shift pressure points.
so technology helps.
It does. But even with the fanciest mattress, the absolute cornerstone of prevention is still manual repositioning, turning the patient regularly.
The famous turn Q 2 hours every 2 hours, is that still the gold standard?
It really is. That regular repositioning, usually every 2 hours, sometimes more frequently depending on the surface and the patient's risk, is what gives the capillaries a chance to reperfuse before permanent damage occurs. It's relentless, meticulous work.
And probably where things often break down in busy settings, the logistical challenge must be immense.
It's huge. Staffing, time constraints.
Mm.
It's why, despite knowing exactly how to prevent them, pressure ulcers are still a massive problem. It requires constant vigilance.
And we also need to know what not to do, right? Things that seem like they might help but actually don't, or could even make things worse.
Definitely. Let's bust a few myths. First, while good hydration and nutrition are important for general skin health, medications like aspirin or statins play no role in preventing pressure ulcers.
Second, compression stockings. Great for preventing venous ulcers by helping blood return, but they do nothing for pressure ulcers, which are about external pressure, not venous pooling.
Right, different mechanism. Third, and this is a common mistake, elevating the head of the bed too high, say more than 30 degrees. Why is that bad? Seems like it would take pressure off the backside.
It might seem like it, but when the head is up high, the patient tends to slide down in the bed, even a little bit. That sliding causes shear force.
Shear.
Yeah, it's a force parallel to the skin surface. The skin gets dragged one way while the bone underneath stays put. This stretching and tearing distortion of the tissue and blood vessels is actually more damaging than direct perpendicular pressure alone. Shear is a major contributor to deep tissue injury.
Wow, so keep the head of the bed lower as possible, or use specific positioning techniques to prevent sliding. Exactly. And another thing to avoid is vigorously massaging the skin over bony prominences. You might think you're stimulating circulation, but you can actually increase tissue tension and potentially worsen damage in already fragile areas. So the mantra is, reduce direct pressure, avoid shear, reposition frequently. Simple physics, complex execution. That sums it up perfectly.
Okay, let's shift now to our final segment. We're looking at conditions that result from the slow accumulation of damage over time, specifically from aging and sun exposure. Let's start with senile purpura, also called actinic or solar purpura. You see this a lot in older folks, these big, dark bruises on their arms. Looks alarming, but the sources say it's basically benign.
It is fundamentally benign, yeah. But it definitely worries patients and families because it looks like serious bruising, maybe suggesting a bleeding problem.
So what's actually causing it? It's not a clotting issue.
No, not at all. It's a structural problem in the skin itself, a direct consequence of aging and, importantly, chronic sun exposure over decades. What happens is the supporting structure in the dermis, the collagen, and especially the elastic fibers that normally cushion and support the small blood vessels, it degenerates. This is sometimes called solar elastosis.
So the scaffolding around the blood vessels weakens.
Exactly. It becomes really weak and fragile. So now, even incredibly minor trauma, like a slight bump you don't even remember or just gripping something, is enough to rupture these poorly supported superficial vessels.
And the blood just leaks out under the skin.
Leaks out onto the dermis, creating those characteristic flat, dark purple patches, technically called ecchymosis.
And the location is pretty specific too, right?
Very specific.
Yeah.
You classically see in elderly patients, usually over 70, and predominantly on the dorsum of the hands and the forearms. The areas that have seen the most sun and minor bumps over a lifetime, they're large, irregular dark purple, and they don't blanch when you press on them.
Now, we know sun damage is the main driver, but do any common medications make this worse?
They can definitely exacerbate it, make the bruising more prominent, even if they don't cause the underlying fragility. Anything that affects blood clotting or vessel integrity can play a role. Think chronic use of steroids, either topical or systemic.
Which thin the skin as well.
Right. Also, anticoagulants warfarin, the newer DOACs, and even chronic use of NSAIDs like ibuprofen or aspirin that affect platelet function, they just make it easier to bleed into that already weakened tissue.
Okay. But the absolute crucial point here, the thing that lets you reassure the patient and avoid a massive workup for bleeding disorders, is the lab results.
This is the key management pearl. Despite the alarming appearance, the diagnosis of senile purpura is clinical, but it's strongly supported, essentially confirmed, by finding completely normal laboratory results, meaning a normal complete blood count, CBC, specifically a normal platelet count. And normal coagulation studies, PTINR and APT, are all within normal limits.
So the blood clot's perfectly fine.
Perfectly fine. The labs rule out dangerous things like thrombocytopenia from leukemia or bone marrow failure, or severe clotting factor deficiency from vitamin K issues or liver disease. The problem isn't the blood. It's purely the leaky, fragile vessel walls due to the damaged connective tissue.
So if the story fits, the location is right, and the labs are normal, what's the management?
Just reassurance, really. You explain to the patient and family what it is, a benign consequence of aging and sun damage. Advise them on gentle skin care, maybe using moisturizers to keep the skin supple, and trying to avoid knocks and bumps where possible. There's no specific treatment needed. The bruises fade slowly over weeks, often leaving a faint yellowish-brown stain from hemocytine deposition. Okay, simple reassurance based on normal labs. Now, let's move from that chronic structural damage to an acute inflammatory response we've all experienced. Sunburn. Seems mundane, but understanding the pathology really drives home why prevention is so vital. Yeah, a sunburn isn't just redness. It's an acute inflammatory reaction triggered by excessive exposure to ultraviolet, or UV, radiation, mostly the UVB wavelengths.
What's the UV radiation actually doing to the skin cells?
It penetrates the epidermis, the top layer of skin, and directly damages the DNA within the keratinocytes, the main skin cells.
Direct DNA damage. Okay. How does the body react to that?
Well, the keratinocytes have mechanisms to detect and repair DNA damage, but if the dose of UV is too high, the damage overwhelms the repair systems. The cells recognize this dangerous situation. Damaged DNA can lead to mutations and cancer.
So they sound the alarm. Exactly. The damaged cells release a cascade of inflammatory mediators, things like prostaglandins, cytokines. This flood of chemicals causes vasodilation, fluid leakage, leading to the classic signs: redness, erythema, swelling, heat and pain, and the peeling that comes later.
If the DNA damage is too severe for repair, the cells trigger programmed cell death, apoptosis. They essentially sacrifice themselves to prevent potentially cancerous cells from surviving. Masses of these dying cells detaching is what causes the peeling a few days after a bad burn.
So every sunburn represents a significant amount of DNA damage, a very significant hit. And this damage is cumulative over a lifetime. It dramatically accelerates photoaging wrinkles, leathery texture, brown spots, that solar elastosis we talked about with the purpura. And most importantly, it directly increases the long-term risk of all major types of skin cancer: basal cell carcinoma, squamous cell carcinoma, and potentially deadly melanoma, especially burns in childhood, which makes effective, consistent prevention absolutely paramount.
It's arguably the single most important thing people can do for their long-term skin health.
Okay, let's equip the listener with the practical toolkit. What are the non-negotiable, evidence-based prevention strategies from the sources? All right, rule number 1. Sun avoidance, especially during peak UV hours, that's generally 10 a.m. to 4 p.m., seeking shade, wearing protective clothing, planning outdoor activities outside this window, that's the most effective strategy, full stop. Okay, avoid peak sun. What about sunscreen? SPF numbers, how to use it. What are the real rules?
Sunscreen is crucial when avoidance isn't practical. You need an SPF of at least 30.
Is higher always better, like SPF 50 or 100?
The evidence suggests that once you get above SPF 30, the additional protection increases only marginally. SPF 30 blocks about 97% of UVB rays, while SPF 50 blocks about 98%. So 30 is a solid minimum. The jump from, say, SPF 15 to 30 is much more significant than from 30 to 50.
Okay, SPF 30 plus what? What about how you apply it? This is where people often go wrong. 2 critical points. First, timing. Apply it 15 to 30 minutes before you go out. Why the delay? Why not right as you walk out the door?
Chemical sunscreens need time to actually bind to the stratum corneum, the top layer of skin, and form a stable, even protective film that can effectively absorb the UV radiation. If you slap it on and immediately go into intense sun, that film hasn't properly formed yet, and you're getting unprotected exposure.
Okay, 15, 30 minutes beforehand. What's the second critical point?
Reapplication. This is probably the single biggest failure point for most people.
How often do you really need to reapply?
Every 2 hours, regardless of the SPF number. And this is key. You absolutely must reapply immediately after swimming or heavy sweating, even if the sunscreen says water resistant.
That water resistant label causes confusion, doesn't it?
Massive confusion. Water resistant means the SPF holds up for a defined period, while in water usually 40 or 80 minutes. It does not mean waterproof or sweatproof. As soon as you exceed that time, or especially if you towel off, you've removed a lot of the protection and you need to reapply right away. Think of the 2-hour rule as the baseline and water sweat toweling as reasons to reapply sooner.
Got it. 2-hour standard, sooner if wet or sweaty. What about clothing? Is that a better option sometimes?
Clothing can be excellent protection, but the type matters. Dark colors and tightly woven fabrics offer much better UV blockage than light colors or loose weaves. Think about holding it up to the light if you can see through it easily. UV rays can get through too. Some clothing even has a UPF rating, an ultraviolet protection factor, similar to SPF for sunscreen.
Good tip. Okay, finally, let's tackle some dangerous myths. Tanning beds. Getting a base tan. Myth number 1. Tanning beds are safe. Absolutely false. They emit primarily UVA radiation, which penetrates deeply, causes significant DNA damage, accelerates aging, and drastically increases melanoma risk. One source mentioned a 75% increased risk for melanoma if you start using tanning beds before age 35. They are classified as carcinogens, period. No protective benefit from that tan. None whatsoever. Myth number 2. A base tan protects you from burning. Also false. A tan is simply visible evidence that your skin has already sustained DNA damage. It offers minimal protection, maybe equivalent to an SPF of like 2 or 3. It's a sign of injury, not health. There's no safe way to tan using UV radiation. Prevention is the only way. Clear message. Avoid peak sun, use SPF 30 plus correctly, early and often, wear protective clothing, and stay away from tanning beds.
That's the recipe for minimizing acute burns and long-term damage. Hashtag tag outro.
Wow. What a tour. 5 conditions all over the map mechanistically, but all telling us something vital through the skin. We went from, T cells mistakenly attacking pigment cells in vitiligo.
Requiring that crucial TSH check for thyroid autoimmunity.
Right, to the pure physics of pressure cutting off blood flow in pressure ulcers.
Where the answer is relentless repositioning, that Q28 schedule.
Then the fragile structure in senile purpura due to sun and age.
Confirmed by those reassuringly normal lab results.
And the complex biochemistry of PCT with enzyme failure triggered by things like Hep C or iron overload.
Managed by phlebotomy or treating the underlying virus. And finally, the DNA damage of sunburn calling for strict prevention. Yeah, the overarching theme really is that skin signs are rarely just skin deep, are they? They're often the most visible window we have into underlying systemic processes, immune function, circulation, tissue integrity, metabolism, even our history of environmental exposure.
Which leads perfectly into a final thought for you, our listeners. Reflecting on all this, isn't it fascinating that for such diverse conditions, the most powerful, high-yield interventions often aren't some revolutionary new drug?
Yeah, think about it. Repositioning a patient every 2 hours, screening for thyroid disease with a simple TSH test, removing excess iron via phlebotomy for PCT, applying sunscreen 20 minutes before going outside and reapplying diligently.
These aren't necessarily complex molecular therapies. They're interventions rooted in a deep understanding of the underlying mechanism, combined with focused awareness and, frankly, adherence to precise protocols.
It really underscores the power of informed, proactive care. Knowing the why behind the skin sign directly guides the most effective, sometimes surprisingly simple, next step, whether that's checking a lab, adjusting position, removing iron, or just applying sunscreen correctly. Knowledge translates directly into powerful action.
A perfect place to wrap up. That's all for this deep dive. We hope this has armed you with a clearer understanding of what the body's telling us through its largest organ. Until next time.